without further ado, let's move into our next speaker. And this again is somebody who a lot of you guys will already have known. You'll recognize the face, you'll recognize the name. We have Professor Subodh Day, very active on Twitter. So you guys will, I'm sure, have come across him at that stage. He's another inspirational figure really within the IMG world. He's done so much for not just psychiatry, but also for general doctors working in the NHS as a whole. So he's a consultant currently in Derbyshire as a psychiatrist. He's currently Dean Elect for the Royal College of Psychiatrists. So if you are thinking about psychiatry training, or you're currently a psychiatry trainee at the moment, then this is somebody that you want to, or hopefully you'd meet at some point and get inspired from. Quite a few passions I've seen from watching Professor Dave's tweets, but co-production, patient involvement, quality improvement are things that stand out as passions of his, and lots of other roles from medical education, but also leadership as well over time. So I'm sure we'll hear a little bit more about his journey and some of the inspirational thoughts that he has that no doubt will help you guys wherever you are around the world. So I'd like to introduce Professor Subodh Dave.
Well, thank you for the kind introduction, and well, congratulations on organizing this exciting conference. Well, you know, it was really fascinating to hear Parveen speak and such words of wisdom. So urge everyone to really follow them. After you invited me, Pooja and Aman, I've now started in my role as the dean. So it's really quite exciting to kind of be here in that capacity as well. And what I want to do today is well, first of all, really welcome everyone to the UK. I know that some of your delegates will already be in the UK, some are probably abroad, hoping to be here soon. I've been here for now more than 25 years, and I can say that NHS is truly, I mean, I may be biased, but surveys have shown, and you know, lots of studies have shown as well, that NHS is one of the best places in the world to health system to work in. Certainly having worked here, I feel that to work in a system where, whether it's a liver transplant or whether it's complicated, you know, lifelong care for somebody who's had a traumatic birth event, all of that is available free of cost to everyone in the country, and to not have to worry about paying for any of your health costs is something that people must have particularly taken note of in the last year with the COVID pandemic. So it's something that I really feel proud of, to work in one of the largest health systems in the world. And so welcome to all of you. Now, I want to start with that whole idea of the international medical graduate. I mean, that's what your conference is, Aman and Pooja, about. And I think relocation in itself is quite stressful. You know, I think when people move from one country to another, and my brother-in-law used to be the director of HR for HSBC, and they had a very large team to kind of support relocation. And I know that for most medics, it's a journey they make alone. For us, I think when you are relocating from not just one country to another, but also from one healthcare system to another, and potentially from, you know, a different language. I think, well, I, like many of you, grew up speaking English, studied in English, but even for native English speakers, moving to England is a different language altogether. And this is a tongue-in-cheek slide, but it's got some truth to it. And I still remember my supervisor saying to me very early on, when I presented a project to them, that it's very interesting. And I think, you know, I think I realize now that they were basically trying to say, well, I don't think I want to know much more about this now. So I think it's a stressful experience for any migrant, and I think it's something. It's best that you acknowledge that early on, that when you migrate, things are going to be fairly challenging. And in the health system for us, I think especially, and I can speak for India, and I think the slide, the points that I put up on the slide there are relevant to my journey coming from India to the UK. That it was a completely different value system. I think there was some continuities, which was good. I think I really valued the fact that I was moving into the UK in a system of psychiatry which felt very familiar. And the diagnostic and the treatment aspects of my science were very similar. But moving from what is largely a private healthcare system of India moving from a system where your teachers are very much your superiors, and the whole hierarchical patriarchal structures, moving from that to a system which is far more egalitarian, where your voice counts, where you're meant to speak up, was a bit of a challenge. And I think that's something that will be useful if you kind of take note of very early on, that even on day one, you have a voice and you should use it. And I think that doesn't come easily to us as international medical graduates. And I think Pavi made the point, and especially if you are an IMG and a woman, and if you are from a different ethnicity, from Black or African descent, all of those factors, kind of these intersectional elements, add up. So I think it's worth kind of bearing that in mind. And I certainly feel that often some of us come from systems where it's been drilled into you that to accept any kind of shortcoming is somehow an indication of failure, and then so it's best not to speak about it, certainly not to speak about it in public, ideally not to speak about it at all. And the system here is actually quite different. The more you are able to talk about your learning needs, and any gaps in your CV, it's not thought of as a criticism. It's actually thought of as being insightful, and then there is a shared onus of addressing that. It's not just on you, it's you and the training system. So my one take-home point today is that acknowledge your strengths, and I'll come to this point over and over again, but also acknowledge your learning needs very early on. And so I think part of the reason why I'm here today is because of the work I've been doing in differential attainment. And I think this is a phrase that has come into parlance in the last few years. When I started here many years ago, we knew that there was a difference in the pass rate of international medical graduates versus local UK trained graduates. But that underperformance wasn't acknowledged. There wasn't any kind of systemic effort to address it, and people were left to their own devices. And it was, well, tough luck. You move to the UK. It's up to you to try and fix that issue. And so I just want to briefly touch upon this. Now, first of all, when you move to this country, recognize, and I think Parveen said this as well, that you're not alone. So if you look at the latest state of the medical education report from the GMC, the General Medical Council, it shows that almost 40% of medical staff is of BAME origin. So there is this, we're talking about Black and Afro-Caribbean and Asian ethnic minority origin. And over the last 2 years, there has been something very remarkable that's happened in this country. So from 2019 onwards, we are seeing that there are more international medical graduates joining the GMC register than there are UK graduates. Now, that is a flabbergasting finding if you think of it, that there are more international doctors joining the GMC register. So you're definitely not alone. In fact, you are the norm now. So that's something quite, fascinating, isn't it? I think, and so when you move to the NHS, when you move to working in the UK, I want you all to feel a part of that family, and then to own that proudly, that you're a part of the international medical graduate fraternity. And there are many of us now. But there is a differential attainment, and I think BAPIO, some of you may have heard of the organization, British Association of Physicians of Indian Origin. They launched a case against RCGP a few years ago, basically because they found that, and the finding was well known, that if you're IMG from BAME ethnicity, then you're 14 times more likely to fail your MRCGP in the first attempt. And the pass rate also varied quite significantly if you were a UK BME doctor as well. So roughly, I think what you find that across all colleges, now this is not a finding restricted to medicine. So I teach at the University of Nottingham in Bolton. I think you find that basically this idea that when you migrate, you don't do as well as local graduates is something that is seen across disciplines. Now, it is particularly important in healthcare for two reasons. One is that clearly, if people's potential is not being realized, that has an impact on the way they deliver care to the patients. And I think ultimately, and I think I totally endorse what Parveen was saying, that your patients come first. And I think if we adhere to that principle, most of our problems would be addressed. And I think a lot of the times that those problems that IMGs face arise because we come from systems where patients being first is not always the case, but put patients first. And I think what you find is that that's not always the case, and I think that's one of the issues. But the second issue, I think, in terms of the attainment gap, I think is that it's seen across all of medicine, and across at all levels. So it's not just in postgraduate training. It's also seen in undergraduate training in UK medical schools. And so it's something that we can start addressing if we are more accepting and acknowledging, more ready to acknowledge the problem. So those are the kind of rough figures there, across all colleges, and you'll find that the figures have been fairly steady and constant over the last 2 decades. Now, this is important because it has an impact on your well-being. And I think we know that exam stress is ranked as #1 cause of stress. And I think all of us who've done exams know that, especially in medicine, they're very high-stakes exams, and they affect us quite significantly. We know also that almost a third of GP trainees were forced to abandon their training due to exam failure. And so people do worry about it. But for us, I think, for us as international medical graduates, this is particularly, and especially those who are from BAME origin. I mean, I think I kind of distinguish between the two, but remember that IMGs come in all shapes and sizes and colors, I think. So we get lots of IMGs from Europe, from Russia, and then from Eastern Europe and the non-EU countries. And they also, so even if they are of white ethnicity, they also face the kind of stresses that we're talking about today. And so the multiple microaggressions, and I'll explain that phrase in a minute. Now, this phrase has been in parlance in the broad debate about the general workforce and trade union conversations. It's not been that common in medicine. And then the final point, and I think I'm going to touch upon it at the very end, is that sadly, a small but a significant percentage of doctors in general, but particularly international medical graduates and doctors from BAME backgrounds, experience mental health problems, including frank mental illness such as depression or anxiety, and demoralization, burnout. And then a lot of that is associated with their with the inability to kind of achieve their personal and professional goals. And so we've been looking at the evidence. I've been conducting a systematic review, and I think the broad themes are this. And I think so. While this is an evidence, I think I don't want you all to ignore your own personal narrative, because ultimately evidence comes from pooled data, but individual stories matter. And I think each individual story adds that richness to the thing. And so for all of us, I think you'll recognize that one of the things is that when you move into the UK, you move to a different health system, you feel different. And that sense of being different is sometimes exaggerated by the way others respond to you and react to you. Our social capital is not as rich as that of local people. So if you clearly, when you grew up in, the Philippines or in Nigeria or in Pakistan, you would have had a whole range of people whom you could just reach out to. So if something's wrong with your car, the mechanic. If something's, you want to find out which school to send your children to, someone to ask. All those, every little questions, getting an electrician to fix issues, getting someone to fit in your dishwasher, all of those things, people. I think when you move to a different country, suddenly all of that becomes a challenge. The whole continuum of discrimination. So the idea that we talked about, the whole differential attainment gap, and that starts becoming more evident to you as you start working in the system. And then institutional factors start weighing in. So you kind of recognize that the institution tends to, and the systems tend to support people or not support people differentially, and sometimes it's unconscious, sometimes it's covert, sometimes it's overt, and I'll talk about that in a minute. And then the level of external support is quite different, and I think certainly support systems for BAME students and for IMGs has been a real issue. And I think this is one of the things I have been highlighting. So like I said, for most global multinational corporations, you find that there is a big team to support relocations, and they support relocation purely the physical aspect of it and help you with your actual move, and then they help you settle in the country. So they help you and sort out things like your license and finding schools for your children, getting rental accommodation, all of those things, and they support you. And then you find that when you're making that very big move or working in another system, having all of that taken care of is a big advantage. But NHS has not done that. NHS, despite being one of the largest employers in the world, despite being one of the largest employers of international workforce, has not done that. And so talking about psychological support and support of supporting you to work in a new healthcare system, that is second and tertiary level of support. But even that initial level of support has not been in place. And that's something that we are working on, people like myself and Parveen, and along with other organizations, and I'll come to that in a minute. But my second take-home point will be is that if you want to address the problem, you need to understand the problem and acknowledge it. And I think for a lot of IMGs, it's a period of bewilderment. I think we don't quite understand what's going on, and we fail to acknowledge and understand what these microaggressions are. So I just want to maybe highlight these for you. So on the one hand is a very clear micro assault, and unfortunately I have to say that that is very rare in this country. Okay, so this is the kind of an explicit racial or ethnic derogation, or discrimination that is directed at you, maybe in a private setting, and then that kind of thing is extremely rare. And I have to say that I have not really experienced it apart from my direct work setting. But I'm a psychiatrist, and when I'm on call, I have, or in my routine work times, I have had patients abuse me racially directly. Now, there is a zero tolerance policy for that sort of a thing. We don't need to accept that. If that happens, if that kind of micro assault happens, raise it. That kind of direct assault happens, racial assault happens, raise it with your managers, and make sure that that is followed up. And I find that a lot of us IMGs don't tend to do that. But the second level is micro insults, and then you'll find that communications that convey a degree of rudeness or insensitivity, but are linked to your racial heritage or identity. And I think that kind of thing is quite prevalent. And I feel that I've been to several meetings where all the white people are addressed by name, and then comes my turn and they say hi there because they don't know how to pronounce my name. Or sometimes people will ask you the question, well, how did you get to become the dean? So it's almost kind of implying that is there, or that is a good time to become the dean because there's so much talk about inequalities, and this is the right time. Almost kind of suggesting that I have not been elected by my membership, which I have been, but somehow there's been some kind of a quota system or affirmative action operating which has pushed through, and that kind of a subtle thing can happen, and we need to confront that. And I think we need to empower ourselves to identify it and confront it. And then there are micro invalidations, and I think again this is basically communications that exclude you or somehow nullify your experience. And I think so, I've been in situations where I've talked about something and they say, yeah, but all trainees experience some kind of a problem. Even if you move from Birmingham to Bolton, it's the same issue, isn't it? Well, it is to some extent. Of course, you have all the issues that go with relocation, but being in IMG adds at another layer. And so if someone's negating that or invalidating that, that's not very good. And I think the reality is that for all of us, we all will have experienced a lot of these things on top of the stresses you experience. I mean, I recall that on the very first day or two, I was making a phone call to my supervisor after having landed, and the telephone box, swallowed my £1 coin, and that single £1 coin loss like haunted me for days, and I think, I came in '95, and we didn't have any WhatsApp or Skype calls then, and there was a telephone system, and Swift call it was called, and you had to send them a check, and I wasn't sure that I could trust the postal system, so I actually went to London to pay the money. Now, these kind of experiences, these kind of IMG specific experiences, are not something that your colleagues might recognize or acknowledge, but the stories need to be told, and I think we need to make our colleagues aware of the kind of things that are happening. The good news is that change has happened in the last few years from the time when I've been talking about it. I think now differential attainment is no longer being discussed as a what, but how to. And I think those of you who have read the the last state of medical education report from the GMC, they've set a very ambitious target saying that we need to fix this attainment gap by 2026, and that the question is not about whether it exists. We know it exists. The question is not about whether we need more evidence to show. We need to kind of start addressing it. And so national organizations like the General Medical Council, all the Royal Colleges, BMA, they all have national work streams on addressing this. So you're definitely not alone, and there are a whole lot of support available. But make sure that you own yourself, own your IMG-ness, own your identity, and are willing to speak up when required. And so we at the college have been doing lots of stuff, and I think I'll talk about that. So we started a national induction. So the kind of thing I mentioned. The weather here is not that great this morning. It's raining quite heavily, and I think that's probably affecting the Wi-Fi signal. Just going back to what RC Stike, the Royal College of Psychiatrists, have been doing, we've really taken this as a serious issue. And when I say we organize conferences for IMGs, it's not for IMGs, it's for IMG issues. And I think so. I'm always at pains to say that we want our UK graduates and colleagues to attend so that they can understand. And this is not an issue for IMGs alone. This is for all of us. And I think gradually that message has seeped through, and now we are seeing that GMC, all the colleges, they all are owning the issue. Your local deaneries, they all now have programs in place to support IMGs, recognizing that it's not an issue. The onus is not on IMGs, the onus is on the whole training system to try and support IMGs. And so we've also been looking at how we support our exams, and then all of that work is in place. Mentoring scheme I've talked about, and that's been really quite a support. We've created a guide for clinical attachment. And I think I would urge you all to look this up if you are in a situation where you still have not arrived in the country, or maybe have arrived in the country but are not yet started your first job. I think having a period of attachment, and you should speak to your employers and ask them to provide that period of shadowing. I think that is quite helpful, and our guide will give you some ideas of how to make the most of that period. But we've also recognized that the onus is not on trainees, and I really want to say that for me, I think the trainers in this country have a big role to play. And so the GMC and Health Education England together sponsored an initiative, funded an initiative that I had devised at the Royal College, and which was really about embedding those courageous, compassionate, cross-cultural conversations in training. So empowering trainers, because what I found was a lot of trainers were finding it difficult to talk to their trainees and talk about their, well, you're from Iran or you're from, Philippines. Well, what does that mean for you to come and work in the UK? And in that kind of conversation, I think we really need to facilitate. And so we've been leading simulated workshops, and the results have been quite positive, and you should be able to see that very soon. Recently, over the last year, we've been engaged in a Bridging the Gap series, and Brenna Isar, Chief People's Officer of the NHS, has been involved. And again, there's been national level support for this program, and the report will be published later this year. So do look out for it. It's called Bridging the Gap, and there are a series of recommendations, including specifically for improving the IMG experience. And there's ongoing research, and so this is a kind of a more theoretical paper around exams specifically as to what are the things that we can do, and so do have a look at it. But some of these ideas will be piloted fairly soon, so hopefully you all will start seeing the impact of these initiatives fairly soon. But there's a lot that we can do as IMGs ourselves. So like I've been saying, I think first of all is to be a bit secure in our identities IMGs, and I find that a lot of the times in this country we have workplace-based assessments, and they have been criticized because all trainers generally tend to give a score of 5 or 6, saying that you're good or very good, and I feel that that is a travesty, because the reality is that all of us are at different places on the learning curve, right? And some of us will be experts in some things, but still novices in another, and then we have learning needs. And so I think trying to kind of figure out how we make the most of our strengths is quite important. And I think having that discussion early on with your education supervisor, so that you can talk about, well, this is my strength, these are my learning needs, this is what I need to do. And then I think if you know what your strengths are, then you feel a bit more secure about getting a 2 or a 3 on your workplace-based assessment. And so for me, I would say that don't be upset if somebody gives you 3. Take that as a learning opportunity and work on it, but also be sure that there's acknowledgement of the strengths you have. So the places where you actually deserve a 6 and you're getting that. Finding a mentor, I think, is absolutely crucial. I think so. If you can do that, a lot of people use their own supervisors as mentors, and I think that works to a point. But I think it's actually even more helpful if you can find a mentor who's outside that system, because your supervisor is going to be a line manager, and so they have a dual role to play. So my one tip would be that find a mentor who's not your line manager, who's not your clinical supervisor or educational supervisor. But your clinical supervisor and educational supervisor should be giving you honest feedback. Speak to them, get them to do more, observations of your clinical practice. So do more. I don't know whether all of you've heard of these workplace-based assessments called ACEs and mini ACEs, or KECs and mini KECs. But ask them to observe your clinical practice and then give you feedback on that. Things like video learning, role play are very helpful. Now, it's always a little bit difficult to video yourself, to hear your own voice, to see yourself on screen, but try and get used to that early. And if you can do that even before you come to the country, even better. But certainly, as soon as you start your placements, try and get in the habit of videoing yourself and then seeing what your communication style is. Now, mixed peer groups. Study after studies have shown that mixed peer study groups are associated with much better exam results than if you are part of IMG only study groups. So, so just make sure that you are not, excuse me, just 1 second. I'm having a little bit of a noise here. Okay, thanks. Hopefully you can hear me properly. So taking part in mixed peer study groups. So I think, again, if you're finding it difficult to find a mixed study group, approach your supervisor, tell them that, look, I mean, I'm an IMG, I only have friends who are IMGs. How can I become a part of my mixed study group? Or speak to your local trainee rep, and there will be a peer group. Speak to them. There will be a peer representative. Speak to them. The reflections, I think so. Also think about, the emotional impact of having moved to the UK. I think, like I said, I think this is quite an important thing, and it's easy to forget that as to how it affects you. I remember very early on, in the very second month itself, one of the nurses I was working with, she sent me a memo saying that I'm calling a meeting to discuss your communication, and I found that really hurtful. I'd done my MD in India, and I thought that I had a good. All my other colleagues had been, in fact, saying that, wow, and in fact, I was promoted as a registrar within the second month itself. So on the one hand, that was happening, and then when this nurse sent me that memo, I found the whole thing quite discourteous and disrespectful. But luckily, I remember that ultimately, I had to work with my patient, so I insisted that the patient and the carer should be invited to the meeting as well, and that was quite helpful, I think, because the patient and carers kind of said that, well, they didn't really have any problems with the communication. So that completely knocked the wind out of the sails of my colleague. But I felt hurt for months and years after that, but that incident really affected me, and I don't really feel I was able to talk to anyone about it. And so I think I would urge that be a bit more explicitly open. Talk about it to your mentor. If you can speak more openly to your supervisor, speak to them, and try and identify what their emotion is. If it's hurt, whether it's anger, or whatever the emotion, annoyance, depression, whatever the emotion is, label it explicitly, and then identify the support. Now, there is support available at every level. So locally, your deanery will have a professional support unit. Make sure you know the number of that place. Put it in your phone, so that you have it available very easily. If you don't know, ask your supervisor. Tell them to give you the list of all the sources of support. There are a whole range of national. So BMA has got, and I've got a slide at the end which I lists all those support systems. BMA has got counseling service. There will be local counseling services through your GP as well. So, and then that's another thing. Make sure you register with your GP. A lot of IMGs, I think, just take years and years before registering with the GP. Don't do that. Make sure you register with the GP straight away. And they can signpost you to the local counseling service, or you can refer yourself. So if you Google IAPT, that's Integrated Access for Psychological Therapy, there will be a local service that will be able to see you fairly quickly. And the waiting list is usually only about 2 to 3 weeks. So just make sure that you are you know about those local and regional and national sources of support. Your employers will also have some kind of a support system in place, so find that out. There's occupational health support available. So you depending on the kind of need you have, support will be available. And there's no need that is extraordinary. Like, like I said, for me, I was told very early on that I speak too fast, and there's support available for that. If your accent is an issue, or if your language skills is an issue, there will be support available for that. uh, so long as you share that with your educational supervisor, it becomes a part of your identified learning agreement that you need support on that particular area. Then it's not just your responsibility to find the solution to that. It's the joint responsibility of yourself and your educational team. So make sure that you create that support very early on. And there are a whole lot of diaspora networks. I mentioned BAPIO, that's British Indian Psychiatric Association, APNE, BP, a whole range of them. And again, they are, if you Google them, you'll find them, but there's also lists on the BMA website, and I've listed them as well. So what to expect from your school? I'm going to try and wrap this up, but there are a whole lot of things you can expect from your school. So if you go to the school board meeting or ask your educational supervisor, who's the champion, who's in charge of IMG issues, who do I speak to? If you feel that your educational supervisor is not understanding the whole thing, your issue, try and escalate the matter. Try and find out what is the school policy for supporting IMGs, and usually there will be someone. How do I find what are the school resources specifically to support IMGs? Ask the question and you will get the answer. Or similarly from your trainers, in your supervision session, you should be getting a supervision session one-to-one with your trainer. Ask them that, how do we make sure that my strengths and my learning needs are taken into account when we design my training plan? If you've got any issues with performance anxiety, any kind of communication issues, make sure that that's highlighted and decided. So I'll stop here. I think this is a list of personal resources, the BMA webpage. There's a practitioner health program, which again I recommend. It's available in England and Wales, and Scotland I think has got something similar as well. It's a free confidential NHS service for doctors and dentists across England, so you can access that for free. And my colleagues who've accessed it have really valued it very highly. So do kind of check them out. There's BAPIO website. There's Doctors in Distress, which I am a trustee of, which again provides support to doctors, as it says, in distress. But there are other generic sources like Samaritans, and I think if you're really down in the dumps and in the middle of the night, you can call your GP, you can call 111, which is the NHS helpline, but you can also call the Samaritans number. So all these resources are available, and I'm sure Aman and Pooja will be more than happy to share that with you. Remember, you're not alone. And feel free to drop me a line if there's anything that you want to raise with me based on my talk today.
Thank you, Subodh. That was go on, Pooja, go for it.
Oh no, you carry on, Aman. Thank you.
Yeah, really interesting talk actually, Subodh, and really good practical things actually that often are overlooked, not thought about, and sometimes pushed under the carpet as well. So I think it was really really good insight to this kind of stuff. And there's so many comments coming through and questions which we'll go through if you're okay to stay for a few questions after. But just from reading those comments, you can tell you've really connected with a lot of people here, and some of the things that you were saying were maybe things that they haven't heard say openly before or talk about openly before. So yeah, really valuable. Pooja, you got anything to add before we go into the questions?
No, absolutely that. I think it's not easy being honest and frank about all these microaggressions, micro insults, and I think it's really refreshing to hear someone talk about it so openly. And thank you for being the flag bearer and helping so many IMGs. That's why we asked you to speak today, Subodh. So thank you ever so much.
My pleasure.
Right,
yeah, perfect. So let's go through some of the questions then, Pooja.
Yep. So one of the first questions that came through is, I believe with this pandemic, clinical attachments are no longer being conducted. Is there any way to go about getting experience? Because even if some trusts are doing it, it's still hard to get that experience in order to start working in the NHS?
So my trust, we provided virtual clinical attachments, and I think there would be other trusts who will do the same. So to try and find out, again, I think initial contact, if you're struggling, I think BAPIO supported a lot of the stranded doctors, people who would come in to do their PLAB and then got stranded in the UK because of the pandemic. BAPIO created a big platform to support them, and I think they got in touch with me and my trust, and I think that's how we arranged the virtual clinical attachment for some of them. And I know that many other trusts have stepped in as well. So do get in touch, and I think if there are any difficulties, then drop us a line, drop me a line, or maybe they can contact you, Pooja and Aman, and I'm sure you both can get in touch with me, and we'll try and fix it, because yeah, we definitely want to try and make sure that people get a flavor of what it is like to work in the UK. And virtual clinical attachments are pretty good. I think we've managed to do so much virtually in the last year that now that there's a real opportunity here for us to make more of that. I think so. Even before you step foot in the UK, you have the opportunity of getting a flavor of some of the working practices in the UK, which I think people should try and grab.
Brilliant.
Yeah, that's brilliant. So there's a question from Harshita. How do you ask somebody, or how should you ask somebody to become your mentor? Any ideas, any tips?
So a couple of thoughts. I think firstly, think about what is it that you need mentoring support specifically with, in what area. So if you're interested in research, and then you think that you really would like somebody to guide you in that, then find an academic mentor. If you think that it's more about kind of managing issues at work, and then you need support with that, I think then it would be a different kind of thing, mentor that you might be looking for, a more pastoral kind of relationship. There are two ways I would suggest. One is that there should be a mentoring lead through your deanery in your local region. So if you Google, so if you're in the West Midlands, Google your West Midlands school or West Midlands deanery, or HEE, Health Education West Midlands, and then that will be the thing for England. And then in Scotland, there will be similar deaneries locally, and then there will be a mentoring lead there. And I think you can drop them a line and ask them to get a mentor. Second way, like I said, is the diaspora networks. So I think contact some of the diaspora networks. Most of the specialties have them. I think if you get in touch with them, they will be more than happy to try and match you up. And then, of course, the Royal Colleges, like mine does, we also have schemes, so we've got a mentoring lead, and we have a scheme specifically for some of the international trainees coming through the MTI scheme, for example, where they get matched directly anyway.
Yeah.
Brilliant. Thank you, Subodh. So next question, I know you touched upon this, but it still has come through as a question, and I think it's important to highlight it again. Just to let everyone know, the chat option is not open for everyone, so don't worry if you can't see it. We can see everything that you guys are typing through, so just type it into the question box. If an IMG has a history of mental illness like depression and anxiety, would it be a problem getting jobs in the NHS?
Not at all. I mean, it's not just depression and anxiety. I think I have colleagues who have psychosis, bipolar disorder, so I mean, I think mental illness is like any other illness, and it can affect any of us, so I mean, there's no us and them. Number one, I think the prevalence of these illnesses, anything from 1% to 4%, depending on, or even higher for illness like depression and anxiety. So statistically, it's more than likely that some of us will have some of those illnesses. But clearly, I think on top of all the stresses I've mentioned, if you have a mental illness as well, then that's going to be adding another layer of stress. And I think acknowledging that early and then seeking support for that early on is helpful. And there's two things I'll say. One is, I think that people often feel very embarrassed about putting it on the records, and they worry about the stigma, they worry about discrimination. I feel I have empathy with that. I understand that, and I think that's true not just for IMGs. A lot of UK graduates have exactly the same issue. They worry about not disclosing their they worry about disclosing their mental illness. And so we know that overall doctors seeking help early for the mental illness is very, very low. Only about 6% of people seek help. The second point is that, but when they do seek help, we know that the treatment rates and outcome rates are very good. Doctors do very well. I think even for problems like substance misuse, which again is a big taboo and doctors don't like to talk about it, success rates are in the region of 80 to 90%, which is unheard of, generally in the general population. So my suggestion would be speak to your GP, disclose it to someone. I think, and I think the earlier you disclose it, the better it is. And there are laws in place to prevent discrimination. So in fact, if you disclosed it, then I think you will have a legal framework to support you if there is any discrimination. So I think you'll be in a stronger position to have disclosed it and then find, because I accept that there might be some stigma and discrimination if you disclose that. That's the reality, but you will have a legal framework. Trade unions like BMA, etc., can come in and support you. And finally, I think a practitioner health program is very helpful. If you still feel that you're not ready, you're not sure whether to disclose or not, go to practitioner health, and there you'll find a medic who probably has had the same experience that you've had, will then be able to talk you through your options and then support you on what to do next. So definitely don't not do anything. Make sure that you do something. So at least if you don't feel like disclosing, make sure you arrange a meeting with the practitioner health program, register yourself there, and that is completely confidential. That won't go on your health records, education records, but they'll advise you on what your next steps are.
Yeah, great. That's really, really good advice, Subodh. And just in the interest of time, I'm going to ask a couple of questions to wrap it up, if that's okay, Subodh. Firstly, we're going back to micro insults that you talked about earlier on in the talk. Someone asked, would ignoring the micro insults by colleagues be a way to avoid the stress caused, or is there a better way to cope? That's the first question. And the second question is related to your recent appointment as Dean of RC Psych. And I just wanted you to elaborate on maybe 3 things that allowed you to reach that position, 3 traits that you think you displayed to get to that position, because it's a position that a lot of people would aspire to. It'd be great to hear your journey through it.
Okay, so the first one, micro insults. I think, well, it's not easy. I think, and calling out each time micro insult is exhausting, and I think, I mean, just yesterday somebody, so in my biography, if you look at the college webpage, my first line says how to pronounce my name. And I think, and Aman, don't mean to the thing, but my surname is actually pronounced Dave. It's not Dave. Yes. But it's a mistake easily made. But so it gets exhausting, and I think you don't have to label it as micro insult because it's obviously not meant like that. But the point is that if you are in a situation where you feel that is likely to impact, and I think it does, if you're in a meeting where everybody else gets addressed, and because people don't know how to address you, they basically exclude you from the conversation, then that's a problem. Then in that situation, it's important that you speak up. So I feel that you have to choose where. So I'm not going to tell them become flag bearers of addressing micro insults all the time, but at least acknowledging and then recognizing when to do it. So yeah, sometimes you have to ignore it, and that's a sensible strategy because it doesn't matter. I mean, I speak to insurance salesmen all the time, and I don't tell them how to pronounce my name. But in certain professional meetings, I make it a point to say, well, this is how my name is pronounced, and I will add in an audio clip if I can or something like that. In terms of the dean, I think 3 things. I think values. I think be aware of your bigger purpose, and I think if you see the post as an aspiration, then that's never going to be great. I think about what is it that you want to achieve through that post, and that is true of every post. So it doesn't matter whether it's going to be a rota organizer or a part of your training committee or whatever. I think each of those roles, think about what is that you want to add value to, and I think and your values will guide you. I think second point, always make sure you put patients first, and I think that is something which is really, really helpful. And I think if you do that, that helps me. And I think we all want to work on the big canvas, and I think as a dean, I'm working on a national canvas, but the joy and gratification you get by actually making a direct impact on a patient or people in your lives is something to not be underestimated. And thirdly, I think I'll reiterate what Praveen said. All of this can sound too serious and can all become, it sounds like sometimes we're lecturing, and we can become almost sanctimonious. So don't ever get sanctimonious about it. Have fun. I think there are challenges in everything we do, and being an IMG is more of a challenge, but then there are people in this country who have other kinds of challenges. So everyone has got some kind of a challenge or the other, and so let's not get sanctimonious and lecturing people. I mean, let's have fun with it. I think there are things we will bring, and sometimes making fun of yourself is a good way of diffusing the crisis as well.
Yeah, brilliant. That's really, really useful insight. And to anybody who is thinking about applying for something or going for an election or thinking, shall I try for that role, bear these things in mind that the Subodh's mentioned now, and have confidence, and like Subodh said, to have fun with it. Trust yourself and go for it, right?
Well,
Awesome.
thank you, Aman and Pooja. That was
Anything else that you want to add on the end there?
No, I think as I said earlier, lots and lots of comments coming through, Subodh, about how you've inspired people and how they can relate to some of the things that you've addressed in your talk. So it really is going to help a lot of people, just knowing that they're not the only ones who go through some of these things. And especially someone in a position like yours, I think it's really important to share those insights, that we are all humans and we all have our own struggles. So thank you ever so much for taking time out today, and we'll certainly forward any queries. So thank you for giving that option to us. Appreciate it. Have a lovely day.
You too. Take care.
Bye-bye.
Bye.
Bye.